To the explainer. Today, we're tackling a really critical area of obstetric care: delivery options after a previous cesarean section. You see, when an expecting mom has had a prior C-section, figuring out the path forward for her next delivery takes some very careful clinical evaluation. It's not a one-size-fits-all situation. The two main options on the table are a vaginal birth after cesarean, which we call VBAC, or an elective repeat cesarean section known as ERCS. So we're going to rely strictly on foundational clinical notes today to unpack the whole shebang: the suitability criteria, the benefits, the risks, and the exact management protocols for both of these pathways.
Okay, let's dive into this. Here is our 6-step clinical pathway for today's explainer. First, VBAC versus ERCS. Second, assessing VBAC suitability. Third, predicting success. Fourth, patient management protocols. Fifth, monitoring for uterine rupture. And finally, number 6, special clinical circumstances.
Starting with Section 1, VBAC versus ERCS, the clinical crossroads.
Let's weigh the options.
When we're counseling patients, laying out this core dilemma clearly is absolutely crucial. On the VBAC side, the upside is massive: a much higher chance of vaginal birth in future pregnancies, a way faster recovery, shorter hospital stays, and you're completely dodging the complications of major abdominal surgery. Plus, it lowers neonatal respiratory morbidity. But we have to balance that against the realities, namely the uterine rupture risk and a fairly high 25% chance they'll still end up needing an emergency C-section during labor anyway. On the flip side, an elective repeat cesarean section practically eliminates that uterine risk rupture and your typical labor complications like anal sphincter injuries. But the trade-off? It's a longer, tougher recovery, a longer hospital stay, and serious surgical risks like DVT and infection. And looking down the road, ERCS significantly cranks up the risks for future pregnancies. We're talking an increased likelihood of placenta accreta, tricky adhesions, and making any future intra-abdominal surgeries a real headache.
Let's actually pause on this number for a second. 0.5%. That is the exact risk of uterine rupture during a standard, properly managed VBAC. To put that into perspective, that's just 1 in 200 cases. It's so important to frame this correctly for the patient. Yes, it is a very real, potentially life-threatening risk, which is exactly why our management protocols are so incredibly strict. But mathematically speaking, 99.5% of these patients will not experience a rupture. It's a metric that demands our absolute clinical vigilance for sure, but it shouldn't cause baseline panic.
Okay, moving to Section 2, assessing VBAC suitability. Let's look at the exact patient criteria.
So, who can safely be offered a VBAC? According to the guidelines, the ideal candidate checks some very specific boxes. First, a singleton pregnancy, so one baby, with the baby in a head-down or cephalic presentation at 37 weeks or more. Crucially, the mother should have only one previous lower segment C-section. Now, what are the absolute deal breakers? The contraindications include any history of uterine rupture, a prior classical or inverted T or J uterine incision, or having 3 or more previous C-sections. And of course, if a vaginal delivery is contraindicated for any other reason, well, VBAC is naturally off the table.
Now you might be wondering, what if a woman has had 2 previous C-sections? Is VBAC entirely out of the question? Actually, the clinical notes say no, she can still be offered one, and the success rate is a striking 70%. That being said, it does come with some pretty major caveats. The rupture rate inches up to 1.4%, and there's a higher rate of hysterectomy and blood transfusion. Because of that, offering a VBAC after 2 prior C-sections requires mandatory in-depth counseling from a senior obstetrician.
Beyond those strict no-goes, there are also personalized factors that can subtly increase the risk of uterine rupture. It's like a clinical puzzle. Doctors have to carefully check if the interval between the last delivery and the current one is less than 12 months. Other red flags: a post-date pregnancy, maternal age over 40, obesity, fetal macrosomia, which just means a larger than average baby, or a low pre-labor Bishop score, meaning the cervix isn't quite prepped for labor yet. They also look at ultrasound data. A lower uterine segment thickness of just 2 to 4 millimeters is a warning sign, as is any history of fever during or after the last birth. Every single one of these variables has to be factored into the final decision.
But it shouldn't cause baseline panic.
Okay, Section 3, predicting success. How do we spot the favorable factors? Let's picture the ideal VBAC candidate. You're looking at the highest likelihood of success if the mother is under 40, has a BMI under 30, and naturally goes into spontaneous labor before 40 weeks gestation. Ideally, her previous C-section was for an isolated, non-recurring issue like a breech presentation rather than a failure to progress. Toss in a high Bishop score and a fetal birth weight under 4 kilograms, and the deck is really stacked in her favor. But we also need to be realistic about what drags those odds down. If we have to medically induce labor, if the maternal BMI is over 30 or, and this is a big one, if her previous cesarean was due to labor dystocia, meaning labor just completely stalled out the first time, while the statistical likelihood of a successful vaginal delivery this time drops off significantly.
Actually, perhaps the single biggest predictive factor is her obstetrical history. If a woman has never had a vaginal birth, her baseline chance of a successful VBAC is around 75%. That's 3 out of 4, which is still fantastic. But check this out. If she has had a previous vaginal birth on top of her prior cesarean, her success rate literally skyrockets to an amazing 90%. 9 out of 10. Basically, a proven pelvis is your absolute best indicator of future success.
Section 4. Patient Management Protocols. The active medical steps.
The protocol demands a very systematic review process long before the patient ever sets foot in the delivery suite. First up, clinicians have to dig into previous records and operative notes. They need to know exactly why the prior C-section happened, the specific type of incision used, and if there were any post-op fevers. Second, an ultrasound is absolutely required to locate and size the placenta. Third, they assess any underlying medical or obstetric conditions like hypertension. And fourth, comprehensive counseling is non-negotiable. The mother has to fully understand her specific success rates, the benefits, and the risks.
Once labor actually kicks off, the rules get incredibly rigorous to ensure maximum safety. You can't just do this anywhere. The delivery has to happen in a hospital with a dedicated delivery suite ready for immediate surgery if needed. We're talking one-to-one care and continuous fetal heart rate monitoring. IV access has to be established right away, complete with a blood count and a cross-match, just in case. They strictly track labor progress using a partogram. And, for anyone wondering, the notes explicitly confirm that yes, epidural analgesia is absolutely permitted during a VBAC. Which brings us to Section 5, Monitoring for Uterine Rupture, the critical safety signs.
Because uterine rupture is literally the paramount safety concern here, we really have to pause and ask, what exactly are the definitive clinical signs during labor that scream emergency and demand immediate action?
The clinical notes lay this out methodically, almost like a checklist for junior doctors. The most common early indicator? An abnormal fetal heart tracing, or CTG. Other severe warning signs include sudden, sharp abdominal pain, especially pain that just won't let out between contractions. Clinicians are also on high alert for abnormal vaginal bleeding, hematuria, which is blood in the urine, and maternal distress signals like a racing heart, a drop in blood pressure, or going into clinical shock. From an obstetrician perspective, if efficient contractions suddenly stop, the belly changes shape, or there's a sudden loss of fetal station, meaning the baby literally moves back up the birth canal, those are massive, undeniable red flags.
So the crucial point is that these are not just theoretical what-ifs. These are strict diagnostic criteria embedded right into the foundational source documentation. If a clinical team spots any combination of these signs, it requires an immediate, total pivot away from the trial of labor and straight into emergency surgery to protect both mom and baby.
Finally, Section 6, Special Clinical Circumstances, the edge cases. Timing and how labor starts can dramatically flip the risk profile. If labor has to be induced or augmented, the risk of uterine rupture jumps up 2 to 3-fold, hitting about 1%, and the chance of a successful VBAC drops down to 60%. Because of those stats, a senior obstetrician has to carefully assess any induction, often opting for mechanical methods like a Foley catheter to avoid the risks that come with certain medications. On the flip side, if a patient naturally goes into preterm labor, the VBAC success rate stays pretty much the same as a full-term pregnancy. But fascinatingly, the risk of uterine rupture actually goes down.
But hey, what about patients who either don't qualify for a VBAC or who just prefer the surgical route? Well, the protocol for an elective repeat cesarean section is just as structured. ERCs is typically scheduled right at 39 weeks. To combat the surgical risks we mentioned earlier, the protocol requires administering thromboprophylaxis to stop blood clots, giving prophylactic antibiotics to fend off infections, and doing a very thorough screening for placenta previa beforehand.
When you get out to the margins of these guidelines, things like post-date pregnancies, expecting twins, older maternal age, or exceptionally large babies, the hard data gets a little fuzzy. In fact, the clinical notes summarize the medical stance with a direct quote. They mandate a cautious approach because there is uncertainty in the safety. In these highly complex scenarios, rigid data gives way to very careful, totally individualized clinical judgment.
And that leaves us with a pretty profound thought to chew on as we wrap up. We've seen the precise percentages, the rigid inclusion criteria, and those really strict emergency protocols. But ultimately, how do we, and how do medical professionals, balance those rigid clinical guidelines with the unique, totally individualized journey of every expecting mother? It is such a delicate equilibrium between data-driven safety and patient-centered care. Thanks so much for joining me on this deep dive into the clinical realities of VBAC and ERCS. Keep learning, keep questioning, and I'll catch you on the next explainer.